So that's step one is just finding somebody qualified to help you find the source of the mold so that you know how to properly get a remediation of the mold. And then step number two, you said were binders. Are there other aspects of treatment that you like? Do you start treatment if somebody's still in mold, or you wait for the remediation to start first? What is your approach in that regard?
While it's absolutely true that you can't get well in a moldy environment, you can get a little better. And I hate leaving people high and dry with, I'm sorry, there's nothing we can do until you get it to a safe environment. I can't do that. I want people to at least be um, not getting worse by at least beginning to take the binders that they need to get going on minimizing that. They can use HEPA filters to decrease it. HEPA filters are imperfect. They won't completely get rid of either mold spores or mycotoxins from any given room, but they help. And not everybody can move instantly. It's financially, socially, economically difficult. So while it's absolutely necessary that they get into a safe environment, one of the hardest part of mold treatment is helping someone to be supported until they are able to get themselves into a safer environment. And that's really hard.
Yeah. So what you use binders? Do you use other things? I mean, are there other like things that you find to be necessary, like things for liver detoxification or
It,
glutathione?
it all depends on the person. Um, in my, from my perspective, which is a little different than others, um, you can you can spend a lot of time detoxifying someone, and I think that is delaying what's really necessary. What I mean by that is I've had a lot of patients have come to me who've spent 6 months or a year just improving their ability to detoxify. That's fine, but what's keeping them from being able to detoxify is the mold toxicity. So I think they're putting the cart a little bit before the horse. The number one thing that a patient with mold toxicity needs to do is to get that toxin out of their body. So my emphasis has been on removing the toxin. Some patients need help with detoxification to do that, and that might mean taking supplements like milk thistle or alpha lipoic acid for the liver, TUDCA to help gallbladder function better, or bitters, working on the biome to a certain extent. But I want to emphasize that one of the hallmarks of functional medicine is treat the treat the gut first, get the biome first, everything else will follow. The exception to that is mold toxicity, which usually has Candida. You can spend 4 years trying to get the gut fixed, and if you're not getting the mold and Candida out of there, those treatments are not going to work. So I think it's important that people recognize that getting the mold out is job one. And yes, there's many other things you can do. There are homeopathics that I use, there's herbals that I use. I like intravenous phosphatidylcholine as a way to help do this as well. But if we lose sight of the key, which is you've got to get the toxin out of there, working around it is nowhere near as effective as you want it to be.
You mentioned Candida in the gut. Um, what do you find? Because I see the same thing that you were talking about there. I mean, it's probably one of the most 90% plus that I see in mold cases. What are you finding successful for that aspect? Do you have them take antifungals? Do you have them take herbals? What kind of tools do you find work best?
I do, and I have the same observation, Peter. I would say at least 90% of my mold patients have Candida also. So same observation. And a quick hint to clinicians in that category is if you're seeing gliotoxin and your mycotoxin test, gliotoxin is made by Candida. So once that lights up, you're literally being told, yes, there's Candida here also. And Candida is notoriously difficult to test for. Our tests, we have some, but not as accurate as we need them to be. So to answer your question, um, when I have Candida on board, typically I will use nystatin, um, working up to a million units twice a day. I may add diflucan to that, and I may pulse the diflucan as one of the first things I do to start treating it. One of the binders I use that will also treat Candida is Saccharomyces boulardii. And that is not only an excellent binder for gliotoxin and zearalenone, by the way, but it helps to flood the GI tract with a benign fungus species and kind of push mold and Candida out. And we've used it in that context for decades already. But the newer finding is that the cell wall of Saccharomyces specifically binds gliotoxin and zearalenone. So it's got a double benefit. So that is what I would do for Candida. And I would then add a biofilm dissolving agent to that once it's on board. There's a number out there on the market which I like. And then I would layer on top of that an antifungal, where itraconazole would be my number one, and I've got others that I'll use.
Okay. In treatment for, if somebody's out of the mold, we're trying to get the candida out of them. What kind of time frame do you typically see? I know it's different. I know it can vary, but in your
It's
patient population.
it's much longer than most physicians think. I've been working with Candida for 40 years. Um, It a lot of physicians think that it goes away with a 7 to 10 day course of diflucan, and in my patients, it doesn't work that way. Often 6 months to a year is necessary of taking antifungals to really get it out of the body. The endpoint for me is urine mycotoxin testing, where when that one comes back not present in every category, then I'm really comfortable that we've gotten the mold and candida out to the point that the immune system can reboot itself and now do its job properly and keep that patient much more protected.
Okay. So we've talked now, I think, in good detail about step one, which is identify the mold and get an inspector. Step two, which is treatment. Let's go into step three.
Okay. Well,
Uh,
step three we've been kind of been talking about, which is adding the antifungals. Um,
the decolonization as a whole. Now, candida for the gut. What do you do cultures of the sinus cavities? You'd mentioned earlier that that a lot of people's sinuses can get colonized as well as their gut.
they can, but I think it's more a clinical diagnosis than a. It's very hard to get cultures accurately. The ENT profession has known for decades that the yield on culturing a known fungus from a sinus is less than 10%. So a normal culture is rarely going to show you anything. More recently, and it's really new, MicroGen DX has some PCR technology where we can go into the sinuses and get a better idea of what's in there. That's adding to what we have been able to do in the past. Um, but often, especially if a patient has sinus symptoms, and if they have a CT or an X-ray of their sinuses showing mucosal swelling, it's a pretty good bet that they have some degree of fungal or candida affecting those sinuses and need treatment. I mean, the Mayo Clinic discovered that back in 1999 when they published their studies about how people with chronic sinus conditions which had not responded to antibiotics were responding to amphotericin B as a nasal spray. So now there's an interesting question in there, and I've recently been talking to some experts about this. In the Mayo Clinic study, their perception was it was an allergy from the fungus that was creating the chronic swelling in the sinuses, and that the amphotericin B was killing the fungus, so it wasn't setting off the allergy. My perception is it's twofold. Yes, that happens, but I think there is a direct toxicity of mycotoxins on the sinus mucosa, and that by doing this treatment, it's even more effective than what the Mayo Clinic found 25 years ago. Back then, they didn't know about biofilm. So one of the things we've learned that's a big addition to treatment is that both Candida and mold make a lot of biofilm in which the mold and Candida hide, protected from both the immune system and the effect of antifungals. So using antifungal, using biofilm dissolving agents is an integral part of what we need to be doing to get it out of the body.
Okay, what do you find there? Do you proteolytic enzymes, EDTA? What do you find the most effective?
I find EDTA the most effective material on the market, and that's the one I use the most. Um, a product that I like is Interphase Plus, which is EDTA orally. And when I use nasal sprays, I'll have the compounding pharmacies put EDTA in the nasal spray to get it out. Some of my colleagues like NAC, which has some dissolving action on biofilm, and then things like nattokinase, lumbrokinase, seropeptidase. A lot of my colleagues like that as well.